Now today we will be discussing about features of renal disorder. Since we are going to discuss about the feature of renal disorder, we have to discuss first about that renal tubules disorder. I have previously discussed also about that when we are discussing the physiology of each segment of nephron. Then in the proximal convoluted tubule, the absorptive defect was known as the Fanconi syndrome, and we have talked about that what are the causes can be, and the main thing is that in proximal convoluted tubule there is a absorptive defect by which all the substances like glucose, amino acids, sodium, phosphate, bicarbonate, everything is getting excreted. It is not being reabsorbed. Okay, so that is known as the Fanconi syndrome. Okay, the causes I have told you about that it may be a genetically like glycogen storage disease, Wilson disease, or maybe due to ischemia, multiple myeloma, or due to drug like ifosfamide, then cisplatin, expired tetracyclines. These are the causes for your Fanconi syndrome. Then there is another absorptive defect in your ascending limb of loop of Henle, and that is known as the Bardot Syndrome, where sodium potassium two-chloride pump is not able to act and there is absorptive defect, because of which sodium and chloride is getting lost from your body, for which to retain that sodium component there is activation of renin angiotensin aldosterone mechanism, and by which renin will be increased. There will be increase in the aldosterone, and there will be one more thing is that urine calcium will be more. I have talked to you that when we are talking about the sodium potassium two chloride channel, if they are absorbed, then only this through paracellular space calcium is absorbed. If calcium is not absorbed, so it will be excreted in the urine, so urine content will be more in case of Bardot syndrome. In case of Glitterman syndrome, which is a absorptive defect of your distal convoluted tubule, there also, since sodium is getting lost from your body in urine, the body will try to retain the sodium, and for that it will activate the renin angiotensin aldosterone mechanism, and there will be increase in the aldosterone, but there will be no effect on the calcium. Actually, in fact, in the distal convoluted tubule, if you remember, we have used the thiazide group of diuretics, then it actually increased the calcium absorption. So since there is only defect in the sodium chloride co-transport, but calcium channel has not been no problem, so calcium will be absorbed more, and in urine calcium will be less. This is the urine, not in the body. In the urine the calcium will be less. That is the one of the main mechanism by which we will be differentiating Bardot syndrome from the Glitterman syndrome. Okay, now the next term is Little syndrome. I have talked about in the previous lecture about the Little syndrome as well. Little syndrome and that syndrome of apparent mineralocorticoid axis, both are the same type of presentation, both are the same disease. Here the Little syndrome, you will find that there will be decrease in the aldosterone. Since there is a decrease in aldosterone, there will be decrease in aldosterone, and here there will be due to deficiency of the 11 beta hydroxy dehydrogenase deficiency. These are the two conditions. Okay, so in Little syndrome aldosterone is decreased. Since aldosterone is decreased, your renin will also be decreased, because renin angiotensin aldosterone mechanism is not activated here, and the BP will be increased. Okay, in CR, what will happen? This is a syndrome of inappropriate ADH secretion. So there will be more ADH. Since more ADH is there, there will be more water absorption. More water absorption may lead to normal BP or increase in BP. Okay, but the plasma renin, since ADH is a syndrome of an inappropriate ADH secretion, there is no relation with the renin angiotensin aldosterone mechanism. There is no relation with the aldosterone, and nothing is related with the calcium. So there might be a BP normal or increase, but it doesn't affect your renin or aldosterone mechanism. When you talked about the primary hyperaldosteronism, in primary hyperaldosteronism, aldosterone is primary deficient is aldosterone is increased. Since aldosterone is increased, then what will happen? It will reabsorb more sodium. If more sodium will be reabsorbed, then there will be increase in blood pressure. That you have to understand. And since aldosterone is increased, but it is not due to the renin-angiotensin aldosterone mechanism, rather it is a Cone syndrome, it is defect of your cortex. That because of that your aldosterone is more renal cortex, which is the zona glomerulosa, where mineralocorticoids is released, aldosterone is released. There is problem because of that. There is no effect on the renin-aldosterone mechanism. Rather, it will be inhibit the feedback. Renin will be decreased. That you have to understand. But BP will be increased. Why? Because when aldosterone is increased, the sodium will be absorbed more. Since sodium will be absorbed more, then BP will be automatically be increased, because sodium and water will be reabsorbed in your circulatory system. When there will be renin secreting tubule, obviously renin will be released. If renin is going to release, then renin-angiotensin aldosterone mechanism will be activated. Aldosterone will be increased, and if aldosterone is increased, then blood pressure is also increased, as aldosterone will absorb more sodium. I have told already about your aldosterone that it will absorb the sodium, excrete the hydrogen and potassium. Since absorb the sodium, it will increase the blood pressure. So you have understood about renin tumor secreting tumor. You have understood a primary aldosteronism. It is due to aldosterone increase, and because of that there will be increase in BP and decrease in renin. When we talked about CR, in CR, the syndrome of inappropriate ADH secretion, since there is more ADH in your body, so more water is absorbed, so you have no problem with your volume issue. So your feedback on aldosterone and renin will be actually low only. Okay. When you talk about the Liddle syndrome is due to this aldosterone is low. Okay, since aldosterone, this is the absorptive defect. Liddle syndrome is absorptive defect, where the sodium channel is actually mutated. Since sodium channel is mutated, your sodium is getting absorbed more and more. Since sodium is getting absorbed, so BP will be increased. But since BP is increased and there is no any affecting mechanism on the renin-aldosterone mechanism to increase, actually due to increase in BP, their parameter will be decreased. Then we talked about Littleman syndrome. We have talked that it has due to absorptive in the distal convoluted tubule. That also be clear. In Bardot syndrome, it is due to the disruptive effect of the reabsorptive effect of the defect of your ascending loop of Henle. In all this is a reabsorption problem. But here is these are defect. There is not reabsorption occur. In Fanconi syndrome also there is no reabsorption in the proximal convoluted tubule. But when it comes to the Liddle syndrome, it is due to the mutation in the sodium channel, and due to mutation there is more absorption of your sodium, and since there is more absorption of sodium, there is increase in blood pressure. That is important. CR is due to more ADH hormone, that because of that more water is getting absorbed and blood pressure may be normal or increased. Primary hyperaldosteronism, it's my name only saying that aldosterone primarily is a disease where aldosterone is increased. Since aldosterone is increased, it will increase the absorption of sodium and decrease renin. Increase BP and decrease renin. Renin tumor, renin will be increased. Primary is renin. After renin, aldosterone is increased. Aldosterone increased, BP is also increasing. By this way, we can explain this term, and we may have a question related to this in USMLE. Thank you.